Welcome to our world. This is your global.
I would like to thank you, Professor Akhil, to given the opportunity to be here in the Sweden, and the greeting from the BHU, India, from the Department of General Surgery. We would like to talk about the very common problems like the sepsis, and that is the multi-drug resistant sepsis, how we deal with in the current era when the superbugs are there. My topic of discussion is the bacteriophage, a possible therapeutic approach to curtail the multiple drug resistance gram-negative bacteria. There is no conflict of interest for this report because this study is my study, and this study is conducted with the collaboration of our mentor Professor Gopalnath sir, with who is the microbiologist at my place, and he is heading the department of the microbiology and currently is the Dean Research. When we are looking to the current scenario, the gram-negative bacterial isolates are day by day increasing, and the spectrum of the bacterial isolates, when we can see in the tropical and periequatorial regions, then the gram-negative bacteria is more in the numbers, and commonest one is the E. coli as well as the Klebsiella species, and next one is the Cetrobacter species, Pseudomonas aeruginosa, Enterobacter, Proteus species, Providencia, Estobacter baumannii, and Escherichia. And commonest gram-positive bacteria is the Staph aureus. And when we see the currently available antibacterial agents and what are the various options available, the drug which are inhibiting the bacterial cell wall synthesis, drug which are inhibiting the protein synthesis, drug which are misreading the messenger's RNA, affects the permeability, and drug which are interferes the DNA functions and causes the leakage from the cell membranes, and drug which inhibits the DNA gyrase and interferes with the intermediary metabolisms. And we can see from last 2 to 3 decades, there are no new antibiotics are recruited in the antimicrobial baskets. And when we see globally, there are a lot of multi-drug resistance bacteria or extended drug resistant bacteria are evolving day by day, and they are creating the problem in the more like the sepsis. And there are the data showing the increasing multi-antibiotic resistance in the bacterial sepsis. And we can see from the 2013 to 2017 that day by day the antibiotic resistance bacteria is increasing nowadays. And still there are no antibacterials or antibiotics are recruited in the baskets in spite of the increasing antimicrobial resistance. When we look into the 1990 to 2025, there are no new antibacterial agents are recruited. So we are running out of options. So what next? In spite of the increasing resistance and no antibiotic is recruited in the era, so we really need to the new possibility. What are the new possibilities are there? That is the bacteriophage. That is the natural scavengers, and that bacteriophage could be the therapeutic option now. As we know, the bacteriophage are nothing but it is a obligate intracellular parasites which multiply inside the host like the bacteria, and using some all host biosynthetic machineries, and it doesn't affect the eukaryotic cells. How the bacteriophage kills the bacteria? Bacteriophage adhere to the gram-negative bacteria rods, and they can infiltrate the genomic material inside in the bacterial cell walls, and they replicate there and multiply and disintegrate the bacteria and assemble theirs. So when we see the history or bacteriophages at the glance, the history is very old. It is started from the 1890, it is from the 19th century, when there the first observation of the phage activity against the Vibrio cholerae, when there the epidemics of the cholera is there, and at that time there the first recognition of the bacteriophage is there. And similar type of the observations while working with the Bacillus subtilis in the 1890. And in 1915, there the Frederick Schwartz reported a similar phenomena in the advanced hypothesis that may be seen. And in 1970, there the first detailed description of the phage during the outbreak of the severe hemorrhagic dysentery, and that is caused by the probably sigilosis. And in 1990, first therapeutic use of the phages and efficacy of the phages preparations in treat of the dysentery was confirmed. And in 1999, there the use of the bacteriophage to treat the bacterial infection, gram-positive bacterial infections, that is the staphylococcal infections. And when you see, there the in 1923, there the Elsevier Institute of the Georgia founded by the George Elsevier, and there the company is work like the commercial level in the 1940. They produced the 7 phages that is used for the human. So how to make the bacteriophage? What are the various process and technology? The bacteria is isolated and propagated by the specific pathogens when the bacteriophage is cultured in the bacterial lawn cultures, and we can harvest the bacteriophage and mass production of the bacteriophages takes place. These are the bacteriophages looking by the electron microscope magnified view. There are 2 types of the phages in the bacteriophage. The one is the lytic cycle, another one is the lysogenic cycles. The phage assembly in the lytic and lysogenic both are beneficial, but lytic phase is more important for the killing the bacteria. So this diagram shows there the phage attachment to the cell wall of the bacteria, and entry of the phage DNA inside the cells of the bacteria, and there they synthesize the viral genome and the proteins, and they can assemble inside and in the huge numbers, and ultimately their cell wall is disrupted and the bacteriophage comes in the nature. In this, we have seen there the lysogenic cycles to amplify the phage productions as well as the possible use of the clinical studies. When there the phage is inside the bacterial cell walls and phage DNA is met with the nuclei of the bacteria, and there the transduction takes place. Our study is in the chronic wounds of the patients. What is the chronic wounds? Chronic wounds do not heal within the 6 weeks of the durations, and because of that, there shows the various prolongation of the inflammatory phase and the wound arrest in the non-healing states. Why the wound healing in the non-healing states? Because of the inappropriate treatment when there any trauma occurs, and it will end up with the chronic wounds. And there are the various other measures in which there are because of the biofilm. Biofilm is the protective covering of the bacteria which is resistant to the antibiotic penetrations, and sometimes there the resistant phenotype is there the multiple drug resistant phenotypes is inside the biofilms, and sometimes there the altered environment, there the so many secretion around the bacteria that can inhibit the antibiotics. So these are the cases of the chronic non-healing wounds on the feet of the previous 6 years old patients, and several rounds of the conventional debridement, local antiseptics, local systemic antibiotics are given, but they are not effective. In these patients, when comes into the OPD, we apply the bacteriophage in their wounds without any debridement and without any antibiotic supports, and this wound heals in the 3 months later time, and limb is salvaged. In this diagram, the duration of healing in the diabetes-related wounds, if we can see there the duration of the healing with the non-diabetic as well as the diabetic wounds. And non-diabetic wounds, the duration of healing is faster as compared to the diabetic. But at the 3 months of the durations, when we can see there the 80 patients of the out of 26, that is 69% of the patients, the diabetic wound heals. Duration of healing as well as the bacterial counts are illustrated in these diagrams. And the bacterial isolates among the cases are the majority of the cases are the Pseudomonas aeruginosa, Staph aureus as a gram-positive, E. coli in the gram-negative ones, Klebsiella pneumoniae, and mixed infection in 13 cases. And when we can compare, they are the most resistant bacteria is the Klebsiella pneumoniae, which takes the longer course of the treatment of the bacteriophage. And mean scores when we compared for the healings by using the Betz-Jones criteria, that is very significant in the all parameters like the exudate amounts or surrounding skin colors or peripheral tissue edema, or if you can see the tissue indurations or granulation tissue, that is very significant when we compare from the day 1 to 21. The conclusion of this study is the topical bacteriophage applications is effective therapy for the treatment of non-healing wounds, irrespective of the drug resistance status of the infecting bacteria in the adults. And it seems to be the bacterial infection associated with the biofilm made the major issue of the non-healing wounds, especially in the chronic wounds, as 90% of them healed by the bacteriophage therapy. And in my study, there is no clinical adverse effect is noted. Further studies are being performed in the acute wounds and result is also very much promising. Then there are the challenges. Challenges is emergence of the phage-resistant bacteria during the therapy that need to be answered. Possible toxicity of the phage is, yes, this is the biggest challenges, need to study it. How the bacteria is eliminated from the body, eliminated or it comes into the lysogenic cycles and it harms to the body, that need to be studied. Transfer of the harmful genes through the transductions and ethical permission for use of the phages as a drug is the main issue. Issue with mass scale production of the phages is another issue that is readily available to the society to treat the such type of the notorious infections like caused by the bacterial biofilms. And there is the need of the multicentric randomized control trial in the specific populations. And thanks to mentors, Professor Gopalnath, who runs the bacteriophage lab at our places, and he is ready to any times to support us and provide the bacteriophage to treat the such non-healing wounds. Thank you so much.
Questions?
Hi, that was excellent and very innovative. Maybe I missed it, but the bacteriophage, are they bacteria specific or they're non-specific? Most of the skin infections are staph, so I'm assuming they're targeted towards staph, but...
Initially, we are using the non-specific bacteria, but when the culture are available and that bacteriophage is cultured on the basis of the targeted bacteria during the long culture in the lab, then we can use the specific bacteria against the bacteria. Initially, we are using the cocktail group of the bacteriophage, that is the non-specific.
I have a question, like this treatment, is it only unique to your place or is it being used other places?
This type of the treatment is, I think, used in the Poland also, here in the UK. At my places, we are frequently used when we are encounter the bacteria is the multi-drug resistant and that is not healing.
Mm-hmm. Have you published this data?
Yeah, this data is published in the International Journal of the Lower Extremity Wounds.
Okay.
Thank you, Professor Bharti. You have an excellent talk and study. Just my query, because you have used bacteriophage in a local manner. It is a locally applied bacteriophage on the wound. But being an intensivist, we have a lot of resistant bacteria in sepsis. It is systemic sepsis. Do you have any idea how we are going to use this phage in a septic newborn where the resistance of bacteria is there?
We do not have any experience about the use of the IV or use of the, yes, oral use is promoted, and Professor Gopalnath are giving the so many times that if the clinician is requested to him, and the Acinetobacter is cured even in the intensive care unit, but our experience is not from the neonatology, so we don't say any words regarding the neonatology. Our study is only topical, but it can inculcate when these answers, these challenges are taken care of, these can be given as the IV. Intravesicals are used at our places also in the resistant UTI. 2 cases of the resistant UTI is treated by me with the support of the Gopalnath sirs, and the urine is clear, and there the pyorrhea is gone.
Just I want to add, I am also from your institute. We have used 1 or 2 cases Acinetobacter-resistant, multi-drug resistant as inhaled therapy. Inhalation form of bacteriophage.
That is also
still
kind of the topical
new
therapy.
idea.
Yeah.
But I am not sure whether it is going to help or not, but there is one form of inhalation therapy also. Yeah. Thank you.
Good. Or
So again, that's an important question. Many of the things that we adopt in the NICU come from the adult world. So the innovation that you are doing is actually translatable, because many a times we have wound infections, right? We have a kid with a G-tube or an umphalitis or a wound dehiscence, and they don't necessarily get into the bloodstream, but caring for that wound itself can be a problem. So to your question, how can we adapt it in neonatology? This could be for those wound infections that are just not healing and getting better. So I do see a role for it. So if you are doing working on future clinical trials, then this would be important to include the neonatal world, focusing primarily on skin infections that are not bacteremic yet.
Yes.
Yeah. But I think the question is also like systemic. Is there any systemic way of dealing with this type of multi-drug resistant? Looks like that needs to be studied more. Yes. Okay. Hold on. Let me just...
I'm also from the same institute. Actually, it's too early to say regarding the use of this bacteriophage for apart from tropical to systemic or the internal route. So we have a good result in the tropical way. So similarly, we are conducting experiment over the animal models to use intravenous as well as the enteral. If results are supported, then we can proceed for that one. So far, we are going for some pilot study, so that will help, and that will reach at a destination where we can decide that it can be used for those purposes. Yeah. We are taking different groups. We are taking almost our 3 sets of patients. We take 1 sets are from the trauma, those who have the acute wounds. Other sets are those who are having the chronic disease, such as diabetes or the vasculopathies. And other sets we are considering the pediatric populations. Yeah. Thank you.
No, that's a great innovation, especially in the countries where multi-drug resistance bacteria is a huge problem. Akhil, you.
Sorry, I have a quick question. What is the specificity of these bacteriophages for specific bacteria? The reason I'm saying this is when I grew up, I always thought E. coli was bad. And then we found that 4% of E. coli actually have a probiotic effect. So the pathogenicity of E. coli comes from a plasmid. Not every E. coli is horrible.
I think you are asking about off-target effects, right? Like if you're giving something, it can also wipe out. Yeah.
Like when I give an antibiotic, then I know which antibiotic affects which genera of bacteria, right?
Yes.
So similarly, are we able to recognize which phages affect which specific genera of bacteria?
Yes. That is the specific bacteriophages. When the E. coli is isolated from the patients, and that E. coli is killed by the bacteriophage in the lab, in the lawn cultures, then we can use that bacteriophages against him.
Initially we use the cocktail, but right now we are using the sensitivity base. We isolate the bacteria, then we create a bacteriophage against that bacteria, then we use. Yeah.
So again, that's a very interesting concept. But then, like, I'm thinking from the perspective of babies. If a baby has early onset sepsis, the baby might acquire the bacteria during birth when it passes through the birth canal. So there is an incubation period, right? So I have very limited time before it becomes culture positive. So can I do a PCR and then determine the specificity of that particular genus that is going to be isolated, and then say, this is the phage I'm going to use?
I think that is the area of research, sir.
Definitely.
That needs the research,
Said is
further
a
research.
good idea, because we have a very less lead time, so that we have early intervene, or we can step ahead of the colonized bacteria of the mother also. Many times it is a commensal or it is in a pathogenic. What Professor Gopalnath sir did, he isolated the E. coli from kids who have diarrhea and who have not diarrhea. And he found what interestingly, the E. coli in a deceased kid has different specific genetics, and those who have without diarrhea have a different specificity. That's the clue, means the bacteria has always adopted a new thing or in new mutation in there, those are pathogenic. So it is important for a specific bacteriophage which is going to help.
That was great discussion, and thank you so much for sharing your thoughts. If there are no more questions, we can end this.